Hey, good morning, everyone.
Good morning.
Great to have you all joining us. And I think we'll still have a few people trickling in, but just wanted to welcome you all today. So, as much as I would love to just have Stevie Wonder dance party all morning, we have some amazing speakers. So we're gonna have to switch gears to focus on that. So, for some of you who may not have met me, I'm Jennifer, I'm Dr. Jackson, and I'd like to start by acknowledging the traditional territories of the people of Treaty 6, the Métis Nation of Alberta, Districts 9 and 10, and the surrounding Métis settlements, as well as the traditional territories of the people of the Treaty 7, which includes the Blackfoot Confederacy, comprising of the Siksika, Kainai, and Piikani First Nations, as well as the Tsuut'ina First Nation and the Stoney Nakoda, including Chiniki, Bearspaw, and Goodstoney First Nations. Excuse me, the city of Calgary is also home to the Métis Nation of Alberta, Districts 5 and 6, and it is my privilege as a visitor to welcome all of you and including our guests. And so this is a great class because we have those of us who are on main campus. We're joined by our colleagues in the Indigenous and rural stream, and also our colleagues at Medicine Hat College. So we're like nursing across the province. Everybody's here. So it's great to have you wherever you find yourself, and I welcome you to join us virtually on this land today. Um, Without further ado, we are going to have three speakers this morning who are going to talk to us about their research. And so you've heard a lot about different types of research throughout the semester, and now you have the opportunity to hear what the cutting edge looks like and what some of the really creative and exciting work is. And so I know I will be inspired, and I hope you'll be inspired as well. So we'll have three speakers for 30 minutes each, and including time for questions. So please, we'll have questions for each speaker as we go. If you'll need to self-administer a break if you need one, and otherwise, I just really encourage you to learn from these amazing folks. So first we have Dr. Lakeisha Cousin, who's joining us from the University of Florida College of Nursing. And Dr. Cousin, I'll maybe let you can say a bit more, but floor is yours.
Thank you so much for the opportunity to come back again, Dr. Jackson. I'm super excited. Let me go ahead and share my screen very quickly. Let's see. How are we looking?
Looks great.
Okay, wonderful. And so I want to talk to you all today. Let me just reset my little timer to make sure I'm within time because I can talk. I wanted to talk today about the importance of incorporating social determinants of health into research, which is very important to me and to my work, and also share some updates regarding my recent intervention. So just some brief objectives. And so what I want you all to take away from today's presentation is how I integrated social determinants of health into my research and also explore the impact of social determinants of health outcomes within the context of my research. Also, please feel free, to use the chat to engage. Unfortunately, I'm unable to see everyone's faces, but it's nice to see any reaction icons also to engage throughout. And so I just want to kind of talk about the definition about social determinants of health. For me coming from the United States of America, it may be a little bit different in Canada, I'm not sure. But I want to talk to you all from the perspective of me being here in the States. And I like to explore these factors because it really talks about the overall health and well-being. And I like this visual because it really talks about how different elements of social drivers influence health outcomes. And it's also a powerful reminder that health is determined by much more than what happens in the doctor's office or in the hospital. And so when you look on the slide, about 20% of health outcomes are directly tied to healthcare itself. Things like care, the quality of care received, but the majority stems from factors outside of traditional healthcare settings. And so 40% of that comes from socioeconomic factors like education, income, job stability, and social support, which I look at a lot in my research, and also community safety. And so these factors just really tie back into where we live. And our zip code really plays a significant role in determining our opportunities for health and also for longevity. And so my research really looks at health behaviors. As you could see, 30% is driven by health behaviors like diet, exercise, alcohol, and smoking, and even also sexual health choices. And so all of these behaviors are influenced by access to resources and the environments that people live in. And of course, 10% comes from our physical environment. That includes housing, access to clean water, air quality, and safe neighborhoods. And so all of these elements together are a picture of health as a product of our circumstances and systems that we interact with every single day. And so to achieve health equity, and as a health equity researcher, I try to address these upstream factors like health, education access, economic stability, and community safety. And all these frameworks remind us of the importance of nursing and how other health professionals advocate for policies and interventions that impact these determinants of health. And so I had a wonderful opportunity to work with some fellows of the American Academy of Nursing, and we worked on defining the social determinants of health for nursing action to achieve health equity. And so it really provides a framework for nursing action to address social determinants of health and also to improve health equity. And so as a co-author of this paper, I had the privilege of contributing specifically on the section of education, access, and quality. And it really talks about how disparities in education impact health outcomes. And it emphasizes a critical role that nurses play in advocating for equitable access to education as an upstream intervention. And so in this work, we highlight the needs for policies at a local, state, and national level to expand funding for school nursing programs, for example. School nurses are positioned to help students succeed academically and also provide preventative health services and also addressing health risk. And I really like how the paper went beyond theory by offering these actionable policy targets like advocating and increased funding for support for full-time nurses in school. So this is just an example of a way that you can actually bring social determinants of health into action related to nursing. And also one side caveat is that it was actually the 2023 Nursing Outlook paper of the year. So it was really important for us to underscore its impact and relevance in advancing nursing's role in achieving health equity. So that was pretty cool. Oops, go back one. And so I really wanted to talk a lot about social determinants of health because I'm also in a service role. I have a joint appointment with the University of Florida Health Cancer Center. And I was also appointed as the Assistant Director of Community Outreach and Engagement. And I also serve as the Clinical Director of the UF Health Cancer Center's Mobile Cancer Screening Connector, as you see here on this image. And so this initiative, I really wanted to highlight this because it represents a significant step moving forward in addressing social determinants of health and promoting health equity in underserved communities, which is my passion. And so this mobile unit was actually launched this fall, and it's designed to overcome barriers to care by bringing vital cancer screenings and health services directly to the communities that face challenges. Social drivers, including lack of transportation, limited access to care, and a lot of financial constraints. And so these barriers are key social determinants of health that can lead to late cancer diagnosis, and poor outcomes. And so through this initiative, I offer services with our colleagues at the Cancer Center. We offer mammography, cervical, colorectal, and prostate cancer screenings. And we also offer primary care and also research navigation. So by meeting people where they are, we aim to reduce these disparities, provide education, and a pathway for follow-up to care. And so I'm excited about my role in the community because I can integrate community outreach with clinical services, and we ensure that we address not only the immediate healthcare needs of individuals, but we have to understand the importance of broader factors that impact health, like social economic factors. We offer free and low-cost screenings to help reduce the financial barriers. We're also providing access to care by helping individuals navigate to follow-up services to ensure this continuity of care. And also education, health literacy, as you all know, as nursing students and as nurses, we must empower our patients and also the community with knowledge about prevention and early detection because it can lead to long-term health improvements. And so this work aligns with my research and the broader mission to address health disparities, particularly under underserved communities. And so when you take a look at the role of disparities in social and structural determinants of health, my work revolves around cardio-oncology. So I look at the impact of cardiovascular disease and also cancer on our patients and our community members. And I really like this framework because there's disparities in cardio-oncology. And this illustrates the influence of upstream factors. And when I talk about upstream factors, I talk about structural racism, sexism, and intermediary factors that include clinical inequities on pre-existing cardiovascular disease and cancer disparities. So when you take a look, for example, at the top of the image here, use my laser pointer. The social determinants of health, that includes demographics, socioeconomic status, environmental, and social cultural. All of these play an essential role in breast cancer risk, stage, survival, and also cardiovascular disease risk among racial and ethnic minority groups. And so these levels of socioeconomic status help shape the trajectory of breast cancer survivorship among Black women, which is a lot of my research revolves around Black women. It's complex, it's multifactorial. And so as you can see here on the left side, structural racism exists in multiple social systems that contribute to care and treatment-related racial disparities in cardiovascular disease and also breast cancer. And my work I wanted to highlight is also in psychosocial factors as well, and also disparities that we just talked about. And so previously, I wrote a manuscript regarding the impact of social determinants of health among Black breast cancer survivors. And I noted that there's a trend of the following top 3 determinants in cardio-oncology. 1, social determinants of health, which I just spoke about earlier. And there's an increased risk of metabolic syndrome between white and Black breast cancer survivors. And so when you think about metabolic syndrome, which is a set of biological factors, obesity, high inflammatory activation, high blood pressure, dyslipidemia, all of these things are linked to a greater risk of cardiovascular disease, type 2 diabetes, and has been associated with an increased risk of developing breast cancer with a worse prognosis and also poor outcomes. But there's also disparities in psychosocial distress, which is an area of my research. Black patients with breast cancer experience these unique social ecological stressors that can really impact overall cardiovascular and cancer risk. And so this article was featured in the Clinical Journal of Oncology Nursing, and the editor asked me to present a podcast. So if you'd like to hear more about this area of research, please feel free to Google it. It was my first podcast, so don't hold me to it. And so I'm really interested in the role of obesity and the bidirectional association between cardiovascular disease and breast cancer in Black women. And so when you think about obesity associated inflammation and insulin resistance, this promotes not only cancer, but also cardiovascular disease. Also, cardiovascular disease and breast cancer themselves can be developed from pro-inflammatory states. And so we can speculate that either cardiovascular disease or breast cancer is additive to obesity in promoting the other condition. Black women are also at an increased risk for obesity, which promotes inflammation, and this leads to this increased levels of inflammatory biomarkers. In the United States, for example, Black women are 1.5 times more likely to be obese than their white counterparts. And so, while several factors likely contribute to this trend primarily reflects social economic disparities that we just talked about. And so, the direct effect of these disparities is reflected in poor breast cancer and cardiovascular disease outcomes, particularly in the southeastern United States. And in Florida, where I live and where I work, the proportion of Blacks in the rural regions are the highest. And so this is the reason why I have the mobile unit. I'm out in rural counties to provide these services. And so, of course, with a lot of nursing researchers, we have to use frameworks to help build our hypothesis with our research. And so one of my favorite frameworks is titled the Superwoman Schema. And the great Dr. Cheryl Giscombe, she developed this framework. She's also a nurse scientist. She developed and theorized and showed this unique race and gender specific experiences that forced this stoic disposition of unbreakable strength in Black women. And so this construct is culturally specific with 5 traits. 1, maintaining this unwavering strength. 2, suppressing emotions. 3, demonstrating self-reliance, don't need help from anyone else. Succeeding despite obstacles. And lastly, placing the need of others before themselves. And so some common scales used to measure the Superwoman Schema include the Giscombe Superwoman Schema Scale, which I use very often in my research. And there's also others called the Stereotypical Roles of Black Women Scale by Dr. Anita Thomas. And so it's very important for me in my research. I'm really interested in these contributing contextual factors like spiritual values and how that impacts physical health. And so we really need to explore culturally tailored frameworks like the Superwoman Schema so that we're able to provide and identify recommendations so that we can improve quality of life for our patients. And so I took a look at a recent qualitative study because I love qualitative studies. It talks a lot about the lived experience. And there were 7 focus groups in the Midwest region of the United States. There are 4 common themes that were found in these interviews. The first thing is that caregiving roles provide the support, which is great, but it also provides challenges because of this traditional gender roles that position women to take on more caregiving in their families. And this can provide both motivation for survivorship, but also a challenge in managing health. Secondly, the strong Black women framework is inherent in the survivorship experience. We know that there may be protective health benefits in being strong and being resilient, but it can also worsen health risk and the obligation to help others. And so we have this intersectionality that impacts survivorship because these women lie at the intersection of race, social class, and gender oppression. And this can make survivorship a bit more challenging for certain people. So I wanted to kind of share 2 of the quotes that I thought were very important from the focus groups. And so Black breast cancer survivors can draw upon a strength identity, which continues throughout their lives. And so I want to read the first quote for you. Because even though I'm going through all of this, I still manage to be there for my sister, my family, I'm doing that because I'm strong enough to do it. Even when I'm really sick, from like all we need to be. I was out there trying to do something. And the last quote, which I took very personally because my grandmother also lived with breast cancer and she did this exact same thing. I didn't want to hurt them, and I didn't tell anybody in the family because I was afraid I would devastate them. And I lived with it for a full year. And when I did tell them, that devastated them even more. And so I vividly remember my grandmother living with breast cancer and heart disease. Never seen her complain about any pain or suffering. We did not know she had breast cancer until the very end. And she always displayed this beautiful, strong Black woman. But now that I look back, I know that she was probably dealing with so many difficulties on the inside, but she still had to carry on this caregiving role. And so I also did a qualitative study, and I wanted to look at the construct of the Superwoman schema among women who are living with pain. For example, with our participants, they had to demonstrate vulnerability and actual physical pain through outward behaviors such as crying, and it's just to have the appropriate care, for example, for pain meds. And it was not easy for women to show weakness, but this was very intentional and real behavior in order to receive basic care and pain management. We understand the problem, a lot of problems still in this 2024, behind breast cancer disparities because of this intersectionality that impacts survivorship. We need to understand and translate knowledge about these cultural frameworks into providing health promotion for cancer survivors. And so my work looks at protective factors to improve psychosocial distress, but I also want to look at physical health outcomes in order to reduce metabolic risk factors among Black women. And so I built the foundation of my program of research way back when I was in the PhD program. And so I was very interested in the impact of positive psychology. When I was a nursing student, I really admired my first mentor, which is Dr. Cecile Lineker. She conducted mindfulness-based stress reduction on cancer survivors, and she looked at cognitive impairment. She also looked at biomarkers of health. And so with my research, I wanted to examine the impact of meditation and gratitude. And so my work was first of its kind in gratitude research, specific to clinical populations. First, I started out with the basic state of the science review. I provided preliminary evidence on the physical benefits of gratitude and identified gaps to suggest that more evidence is needed, especially with physical health outcomes. Second, I created a model called a structural equation model where I concluded that self-efficacy can mediate the relationship between gratitude and health behaviors among patients who are living with stage B heart failure. And lastly, I was the first investigator to measure dispositional gratitude or long-lasting gratitude among Blacks at risk for heart disease. I developed a study called the Grateful Heart and Soul Study, and I recruited almost 300 African Americans at risk for cardiovascular disease and found that gratitude is positively correlated with positive affect and spiritual well-being and negatively correlated with depressive symptoms. And so we really must begin with understanding the definition of gratitude itself, right? And so gratitude is a disposition or a tendency to recognize and appreciate the positive aspects of life, both big and small. And so I always talk about the definition of gratitude with a two-step process. Step one, affirming goodness. And so this step involves acknowledging the goodness in our lives, the good things in our lives. It's about recognizing that despite the challenges, there's goodness present. This can include anything from like supportive relationships to opportunities we have or the simple joys in life. And for us, it's patients coming out of surgery, right? And I was a transplant nurse and receiving a new heart, a new lung, for example. Step two is recognition. This step emphasizes the understanding where goodness comes from. It's often external, it's beyond ourselves. For example, it may stem from efforts of others, a higher power, the natural world, or just depending on one's beliefs. And so by affirming this goodness and recognizing sources, it can emerge as a powerful trait. And that's what I'm interested in. And so I also wanted to mention that in 2024, this year, JAMA Psychiatry actually published an article based off of older nurses, 49,000 to be exact, in the United States. And the objective was clear, just to explore whether gratitude impacts all cause or cause-specific mortality. And the findings, in my opinion, were very compelling. They found that greater gratitude at baseline was associated with a 9% lower hazard of mortality, even after adjusting for multiple factors like social determinants, social participation, and religious involvement. And so it actually just helps me with my research. Of course, I love to cite this because it talked also about the protective effect of gratitude with cardiovascular disease, a 15% lower hazard. And so it highlights the potential of gratitude to contribute not only to mental health, but also to physical health, especially in reducing cardiovascular disease risk. And so very quickly, I want to talk about my research and the problem that stems from my research question. How can we examine facilitators of behavioral change to promote well-being and exercise readiness to reduce cardiometabolic risk? We know that physical inactivity is a problem, not only with Black women, but across the board, right? And so I'm looking for ways to change health behaviors. And so with my research, I call it GYM, which stands for gratitude, exercise, self-efficacy, and mindfulness. I'm not sure if anyone's familiar with this quote, but this is a quote from Lauryn Hill. Don't be a hard rock when you really are a gym. Respect is just the minimum. And so it's my pilot intervention, and it was based off of gratitude, and it was a clinical trial. So if you're interested, please feel free to screenshot that for more details. But the objectives were very clear. It was a feasibility study. So I assessed the feasibility and acceptability of a gratitude journaling intervention. And so I looked at factors like gratitude trait, spiritual well-being, distress, and exercise readiness. More importantly, I also looked at inflammatory biomarkers from baseline to post. The reason why I started out with the feasibility study is because I'm looking for ways to design a larger and bigger and better randomized control trial to test the effects of my intervention on biobehavioral outcomes. And so it was an 8-week, two-group parallel design randomized control trial where I had two groups that were either randomized into the gratitude group or the control group. My participants were 26 Black women who were 50 years or older with a history of breast cancer. And so some of my feasibility metrics are listed here. Focus on recruitment and retention, if they liked the intervention, if they were satisfied with the intervention. But also, I wanted to look at secondary outcomes, all of the variables that are listed here, and including inflammatory biomarkers. And so I had opportunity to approach 40 women. We did exclude 14. Some of them were already meditating or exercising frequently, but we were able to randomize 26 Black women into two different groups. We did lose a few to follow-up because they were unable to go to the research clinic because of transportation issues and work issues. And so here's just a list of our data analysis. I did descriptive statistics, paired t-test, and also I did biomarker analysis to determine the changes in the biomarkers listed here. And so the average mean age was 65 years. About 46% had some college education, 1 to 3 years. And also about 19% completed a high school or had a GED. But it varied with employment. And so about 30%, 35% were employed full time, but notice the income. Um, Over half were not working, and also the income range between 25 to 50,000, which was about 35%. Most of them identified as Christian and also were obese, if you take a look at the BMI, and most of them were single. So very quickly, because unfortunately I'm running out of time, but I want to share some of the key results. 73% of our participants completed post-intervention assessments, which I was very happy because, it was quite challenging to convince my participants to have their blood drawn. But 100%, we met recruitment goals. And they also reported high satisfaction with the intervention. We did have some small to moderate effect sizes. The most significant finding was, of course, spiritual well-being, which was great. But I was hoping to see more change in inflammatory biomarkers, but we have to understand it was a very small group and it was only 8 weeks. However, with the Superwoman schema, we did see a medium effect size in emotional suppression and vulnerability, which was a small improvement. So some key takeaways I would like for you all to take away from my intervention was that it was feasible, it was well accepted, there was improved spiritual being and exercise self-efficacy, which kind of highlights the potential for promoting holistic wellness. But more importantly, this allowed me to set the foundation for my larger study. And so just last month, I resubmitted my intervention to the National Cancer Institute. So please pray for me because they will be reviewing my application on January 27th at 9:30 a.m. So fingers crossed. But I'm very excited because I actually incorporated some community support within this intervention. So just taking a quick look at the model, as you can see that there are a lot of different factors involved. Previously in my initial feasibility study, I looked at individual level factors, but I also want to incorporate interpersonal social support and also community level factors like social vulnerability and finding ways on how my intervention can impact cardiometabolic risk. And so my ultimate goal is to have a toolkit for breast cancer survivors to take home with them to encourage journaling and mindfulness. And also, group sessions are very important. In my intervention, I have group mindfulness sessions and also gratitude circles to help promote and reduce stress. And also, I'm very interested to see how protective factors and resiliency can impact certain communities and how social vulnerability plays a big impact in this as well. One way to do that is to provide resources, right? And that's one way I'm doing that through my service and also through my research. And so I wanted to acknowledge the University of Florida. They've been very supportive for me since I started in 2021. The research that I recently talked about was funded by my Career Development Award, which was provided to me by the National Institute of Aging. Also, I want to give a quick shout out to the National Institute of Health and the National Cancer Institute because I was an early investigator advancement scholar, and they really helped me advance my recent submission. Also, I want to give a special recognition to Nicole Miller, who is a breast cancer survivor who helped me recruit for my study. She's also the president and CEO of Blossoming Butterfly. And lastly, as always, I dedicate my research in honoring the legacy of my grandmother, who I just talked about earlier, Maddie Lee. She died in 2012, right when I became a nurse. And she is a true gem in my life, and she's the reason why I do this. And so I just want to thank everyone and open the floor if you all have any questions for me. Oh, thanks
Please,
for the prayers.
please join me in clicking your clapping emoji to thank Dr. Cousin. It's amazing to hear about how you've connected these positive psychology concepts with the biomarkers. And it's too bad the pilot wasn't significant, but hey, bigger sample, Next round, right?
Yes, next go around. But I think what was really great was the fact that I had one significant finding, and that was spiritual well-being. And although we had no significant findings with biomarkers, I'm hoping with a larger sample size, we can get something, right?
Yeah.
That's what I'm hoping for.
Well, I know our cohort here had did some work with randomized controlled trials, so that was less awesome. So it's great to now they can see what a really good one looks like, to get that kind of perspective on the difference your work is making.
Thank you.
So, any questions for Dr. Cousin?
Hi, my name is Val, and I just wanted to say thank you because my grandma also died in 2012, and that's when I became an LPN. It was my grad year. And so now I'm going to become an RN, and I really love Florida. And there's a lot of, we've been there a couple times. There's a lot of similarities between the indigenous population and the Black population with poverty, with the superwoman stuff. And um, I just wanted to thank you, and it's really awesome. I'm just looking forward
Yes.
to a break here, but you've really inspired me just to keep going.
Oh, and I really appreciate you sharing your story with me because this is one of the reasons why I always share about my grandmother because you never know who you can touch and who has a very similar story. And so that truly made my day to make that connection of the same year and the reason why both of us became nurses. So thank you so much for sharing that. Thank you.
Thanks, Val. Well, I don't see any other questions. I know a lot of people have been very excited by your presentation, but um, I guess thank you so much for joining us in our class today, and uh, keep in touch. We want to hear more about the trial.
I'll let you know if it gets scored, Dr. Jackson. Fingers crossed. But I'll stay on a little bit to hear the other speakers. I have a little time now. Thank you.
Great. Thank you so much. Um, So I like already we win and we still have two more great people to share their work with us here today. So our next speaker is Jess Crawford, and they are joining us from Manitoba, I believe. And they will be telling us a bit about their work in terms of perspectives on gender inclusive and affirming practices in nursing education, or perhaps the lack thereof. So, Jess, I welcome you to share more about yourself and turn it over to you.
Wonderful. Thank you so much. And I always struggle getting my computer situated. I'm going to share that screen and go to my presenter view. No, you can see the wrong screen. And my puppy is also here, active in the day. Wonderful. Thank you so much for inviting me to speak with your class. It was also very lovely to listen to Lakeisha. And I also just wanted to acknowledge and situate myself according to your research interests, having been a nurse in a high school, and then also being involved in cancer health equity research as well. So thought that was cool overlap for our work. Yeah, so I'm Jess Crawford. I use they, them pronouns. I am a trans, non-binary, and queer registered nurse and Master of Nursing student. I did defend my thesis in the fall, in October. So just moving through the process of getting those letters official. I'm also a white settler uninvited guest with British and German ancestry, and I reside on Treaty 1 territory, or so-called Winnipeg, Manitoba. This is the traditional territory, land, and water of the Anishinaabeg, the Innunuak, Assininuak, Dakota Aote, and Dene people. and the homeland of the Red River Métis. And the Manitoba Métis Federation just signed a monumental self-government treaty last week, recognizing their inherent ability to self-govern themselves. So that is really exciting. And I want to share a few pictures. So this is when I visited South Glenmore Park in Calgary. That was my first time there. It is nice to know there are people from all across your lovely province joining the call today. But this is me birding, which is something I like to do, and it was really nice to be out there and experience that land. This is last week. It looks worse now. The Red River, where I walk and brainstorm about my thesis work and how to be a good relation. And this is the aforementioned puppy in the fall at a marsh that I like to frequent. So just showing you some of the land and water that I'm really gracious to be able to care for and learn from. Before I go on, I really would love to hear what your research interests are. When I was at your stage in my undergrad, research was really not of interest, and I am still kind of shocked that I've obtained my master's. And so I'm wondering if folks want to put in the chat anything that you're interested, thank you for the cute dog comment, in potentially researching, topics or ideas that you would be interested in looking at. Would love to hear, or even like methodologies or types. If anyone has any ideas. And I will let you percolate on that, and I will continue forward. So I'm really excited to share my thesis work. As I mentioned, I successfully defended it. It was called Student and Faculty Perspectives of Gender Inclusive and Affirming Practices in Undergraduate Nursing. And I must mention the amazing support that I had from my thesis committee, in particular my advisor, Dr. Annette Schultz. And I'm seeing the couple of comments: maternal health, cancer research. It's wonderful. Indigenous health. Yeah, these are all, and anything can be researched. And I'm hoping to show you some of the ways in which research can be leveraged to make change, to share stories and to gain the power from those stories and make change. So thank you so much for those of you who put things in the chat about what you're interested in. So my outline for us today, we're going to go through the background of my research. I'll give you the purpose, theory, objectives, and methods used in my work. Then I'll take a little check-in to see some of the jargon, see how things are going, if anybody has any questions halfway through. And then I'll go into my study findings with implications, strengths and limitations, and some key takeaways. And then again, offer some space for questions. But of course, you can also use the chat. I will do my best to monitor it as well. All right, so let me provide some context behind the basis of my research. So firstly, nursing education is intended to provide the knowledge and skills necessary for the next generation of nursing students to equitably care for all people. Nursing education has a responsibility to both educate about and be a place of equity, diversity, and inclusion. But there remain critical gaps in how this is being actualized for many diverse groups, such as trans and gender diverse people. Trans and gender diverse people are an equity deserving group with unique healthcare needs, which can be addressed through the provision of gender affirming care. Nurses are the largest health workforce, and we can help meet this need. And nursing schools in Canada produce hundreds of nurses annually, in the States over thousands. And thus are critical places which can begin to address gender affirming care. So as part of my thesis, I conducted a scoping review of the literature, and this revealed that there have been increases in formally teaching gender diverse content or gender affirming care. However, there are gaps in appropriate and embedded content across all of the years. And further, steps to address inclusive and affirming environments for trans and gender diverse people within nursing, such as nursing faculty and students, were absent and invisible in the literature. And so my thesis aimed to address these gaps. The purpose of my research was to critically examine gender inclusive and affirming practices in undergraduate nursing education. So what are those practices? What does that mean? Several theories guided my work, and And I know theory can be a bit boring, but these are really important to set the frame of thinking. So I'm going to walk you through them a little bit. So first I use the 3 levels of curriculum, which are the 3 dimensions in which learning occurs in education. So as I go through these, even think about the ways you experience your different levels of curriculum according to your positionality and situation. When we think of curriculum, we frequently think of what is learned in the classroom or in textbooks. This is called planned learning or the formal curriculum. And this is actually only one way that students learn. We often give the most amount of energy towards the formal curriculum, but students also learn from the informal and hidden curriculum, and arguably more so from those realms. The informal is that which is learned through interactions, and the hidden is learned through the culture and environment of an institution. I also used queer theory to guide this work. Queer theory with a gender-specific lens allowed me to interrogate or look at power norms and othering, and it provided the language and framework for understanding how to critically approach normative systems such as cisnormativity. And just a quick blurb, cisnormativity is the process of naturalizing people that are not transgender, so cisgender. So to clarify, cisgender folks are non-transgender people or those whose gender aligns with their sex assigned at birth. And trans and gender diverse people, such as myself, are those whose gender does not align with their sex assigned at birth. So the combination of the 3 levels of curriculum and queer theory allowed me to create gender inclusive and affirming practices. And so critically examine gender across each level. And after getting a sense of the literature through my scoping review, which I'm not going to talk about today, but it was published, so you can read it if you'd like, there were 2 key research objectives. The first was to explore gender inclusive and affirming practices, and the second was to revision or reimagine these practices for nursing education. So my thesis was guided by Thorne's interpretive description. Sally Thorne is a nurse researcher out at UBC and created this methodology or this way to go about research to be a really logical, flexible approach with practical application. So the idea was for nurses who are practical workers to bring and be able to apply their research in real meaningful ways. So in this portion of the study, I engaged with nurse educators and students through interviews and focus groups, respectively. And to meet the first objective, initial data collection explored gender inclusive and affirming practices with participants, and the second was through follow-up data collection, which addressed the second objective. So I'm just going to take a break here. Thank you for putting the final paper in there, Dr. Jackson. Are there any questions so far? Talked about theory and a little bit about methods. I'll just give it a minute
Yeah,
there.
interpretive descriptions, one we've talked a bit about, but it's great that we'll have a real world example. So
Cool. Yeah, at first I was really apprehensive. I mean, a methodology is a bit daunting, but interpretive description was really, it allowed me to do whatever I wanted. It gave me some parameters to make sure that I was being rigorous and accountable and transparent. And then I could really, do what I wanted, get the sample size that met my needs, do the approaches such as the interviews and the focus groups, and have a rationale behind that. So, okay, I'm not seeing any questions, so I'm gonna move on, but if anything comes up, do let me know. Okay, so now I'm gonna go into my findings. So to meet the first objective, sorry, just moving the images here. Initial data collection explored gender inclusive and affirming practices with nursing students and educators. So this included 18 student participants across several focus groups and 7 interviews with 7 unique educators. At the time of data collection, 8 or 44% of students self-identified as trans or gender diverse, Additionally, among the students was intersex, queer, disabled, and racialized representation, including First Nation and Métis participants. However, nobody identified as Two-Spirit. And all educators were cisgender, and there was queer and racialized representation among them. So through interviews and focus groups with these two groups, I explored their experiences of gender inclusive and affirming practices, and here is what I found. So at the level of the formal curriculum, which was discussed quite at length by both groups, likely because, as I said, it's the easiest to recognize, it's the one we spend the most time on. You know, we look over our syllabi and we see what we're going to be learning or we're preparing for. So here, both participants groups indicated there are some educators that are champions of gender inclusive and affirming practices, meaning that they were teaching gender affirming care content or offering supports and advocacy to trans and gender diverse students. However, these champions were often rare, and there were concerns about the sustainability of having one person make these practices live throughout an entire undergrad curriculum. So leaving it up to one person was just not enough. Another experience was that trans and gender diverse content was missing in formal learning. And when it was present, intersectionality was lacking, wherein whiteness and non-disabled bodies were often assumed, for instance. And perhaps a reason for the missing education was the experience of students and the reports from educators of feeling unprepared to teach trans and gender diverse content, with no educator participants having received any meaningful education on gender affirming care. So the educators themselves didn't know how to teach this content or what to include, so they didn't have the resources. And then the students really felt that. Looking at the informal curriculum, so again, this is language and relationships and interactions with peers or instructors or faculty, or even clinical preceptors. In my analysis, I noted language use, which conflated concepts of sex and gender, such as using terms like male and female, incorrectly interchanged with gender concepts of man and woman. And the conflation of concepts of sexuality and gender, wherein participants often grouped sexual and gender diverse people as one and the same, when in fact they are very different and unique. In some instances, students would offer corrections to these mistakes or conflations and be scolded. And this included a trans and gender diverse student who was told they were being transphobic for suggesting that trans and gender diverse people do not fall under sexually diverse groups. Other negative interactions included educators who received negative comments when mentioning they chose to teach trans and gender diverse content. And meanwhile, students, including trans and gender diverse students, would become unwilling and unknowing sounding boards to anti-trans dialogue in the classroom and in clinical placement. And so lastly, the hidden curriculum revealed that School of Nursing environments were not gender inclusive or affirming. Students and educators were rarely able to indicate protective policies and procedures for anti-trans violence or discrimination. Few can pinpoint inclusive and affirming washrooms, and none had any trans or gender diverse representation among their faculty. And just for reference, our participants were across all the provinces. We did not have anybody from the territories, but there were about 25 different schools represented across participants. Participants were also frustrated and felt hopeless that nurse regulators did not impose gender affirming care as part of accreditation, licensure, or the NCLEX exam. And this was because they recognized that what is prioritized in terms of teaching and nursing education is often dictated by accreditation, licensure, and the NCLEX exam. So when I synthesized or really put it all together, I compared participant groups and I found students and educators had differing priorities. Whereas educators were focused on teaching gender affirming care, which, as we know, is part of their responsibilities, teaching. Students were acutely aware of the multiplicitous ways that cisnormativity prevailed across the curriculum. And it impacted them different, probably because almost half of participants were gender diverse, and so experiencing that very differently. And so regardless of their differences, both groups offered insight into the presence of cisnormativity across all levels of undergraduate nursing education. So going back to the concept of cisnormativity, as I mentioned earlier, it's the naturalization of cisgender people. So this is an ongoing process of identifying cisgender people as normal and morally acceptable. And it also naturalizes the othering of trans or gender diverse people. So it's a simultaneous process wherein anything outside of cis norms, being trans and gender diverse folks, are deemed abnormal and immoral. And I should mention, this is a system that is created and perpetuated really without our knowledge or awareness. So bringing it into light is aimed at helping us recognize it and then move forward and disrupt that. So cisnormativity was perpetuated when gender affirming care was set to the fringes, such as in formal curriculum, when language remained highly gendered or conflated with sex or sexuality, as in the informal curriculum, or when there was no trans representation or limited access to gender inclusive and affirming washrooms or policies, as in the hidden curriculum. So what are the consequences of cisnormativity prevailing in these ways? So there are two key ones. The first is the impact on trans and gender diverse patient care. This was evident by nursing students not feeling prepared to care for trans and gender diverse people, and nurse educators not being prepared to teach this content, many wondering how they were supposed to teach it if they didn't know about it themselves. Further, educators felt that not educating students on gender affirming care was widening the health disparity gap for the community. So when educators are not equipped to teach gender affirming care and students are unprepared to provide gender affirming care, ultimately trans and gender diverse patients suffer. And this is especially important because students will care for trans and gender diverse people because we make up at least 1% of the population, as one educator pointed out. It's more likely 2 to 4%. Another consequence of cisnormativity in nursing is the impact on trans and gender diverse nursing students. Trans and gender diverse students experience the 3 levels of curriculum differently than their cisgender counterparts. They felt othered and invisible, which was amplified by the lack of representation in formal curriculum, language, and amongst nursing faculty in their environment. They ultimately got the message that trans and gender diverse people do not belong in the academy or in nursing, leading some to question their place in nursing. They also expressed feeling burnt out from acting as pseudo-educators with worries that if they didn't become the tokenized encyclopedias of trans knowledge, their peers would not get vital knowledge on providing life-saving gender-affirming care. And they also expressed experiencing and bearing the brunt of transphobia and had no avenues to navigate these situations within clinical or in the classroom. So while some of that was bleak and a wake-up call, part of this study included a reimagining exercise, which was meant to draw power and inspire the future of nursing education. And this was taken from the queer theory lens. So again, just bringing theory back in to show you its power, and hopefully you've seen how the 3 levels of curriculum theory has come into play as well as very important. So this exercise also helped to meet the second objective of revisioning gender inclusive and affirming practices, and it added depth and rigor. So because I was doing follow-up data collection and met with participants again, we were able to get more depth of understanding. Our relationship was deeper, and so I was able to confirm some of their experiences again, and it just added to that process. So of the 18 undergraduate nursing students, 13 returned to attend focus groups, which were shuffled based on people's times that they could attend, and all 7 nurse educators returned. Through this exercise, key recommendations to move gender inclusive and affirming practices forward emerged. The first was education in gender inclusive and affirming practices. This was integral that both students and educators were the ones that need education. Students really wanted intersectional representative learning opportunities, as well as the normalization of trans and gender diverse content read throughout the entire curriculum of nursing. So there's a quote on the side: in a dream world, it's embedded and it's not presented as like, oh, this is the unit where we learn about trans people. Just like, oh, like this is part of the diversity of humans. And in these recommendations for today, I have kind of focused more in on what the nursing students had said, because that's the focus of this group today. So the second recommendation participants had was for accountability of schools of nursing. So while they didn't always have similar views on what accountability looked like, especially between student and faculty groups, students wanted clear policy and procedures for reporting anti-trans discrimination. For instance, one student suggested navigating discriminatory concerns about an educator with remediation and restorative practices. Thirdly, participants wanted improved trans and gender diverse representation among students, educators, and leaders. by admitting, recruiting, retaining, hiring, and empowering trans and gender diverse people in the academy and in nursing. So the importance of role models and advocates and people that look like you in the academy is really, really important. In addition, there were calls to expanding environmental representation. So this would be through gender inclusive and affirming and accessible washrooms, which are also menstrual hygiene equipped, recognizing that a diverse range of people menstruate. And lastly, beyond schools of nursing, participants wanted more action from regulators by explicitly including gender affirming care in licensure, examination, and accreditation requirements. So those three things that really drive education. A participant saying it's a whole systems change. It's not just trans people that we need on board, but everybody. So ultimately, both groups felt that multi-level action was needed to disrupt cisnormativity within and beyond the nursing, beyond nursing education. So what are the implications? Drawing on my thesis and then leveraging interpretive description's practical approach, it's important for me to further ground how we can move forward with gender inclusive and affirming practices in nursing education. So firstly, to reiterate from the revisioning exercise, I know I just went through it, but it's really important. And the participants really hit the nail on the head. And so they felt that it's crucial responsibility of nursing education to disrupt cis norms by supporting and providing resources for educators to best include this content, embedding gender affirming care across the curriculum, and empowering trans and gender diverse students. Another implication is for nurse regulators, who also bear responsibility as indicated by participants. They can facilitate a systemic shift in nursing by making mandatory explicit requirements that gender affirming care content needs to be in curriculum and as a requirement for obtaining and maintaining one's license. And lastly, while there are so many more, lastly, for nursing research, we can begin to address some of the gaps. So vital in doing research with this community is including trans and gender diverse people and using critical lenses. Research avenues that make visible cisnormativity, developing, implementing, and evaluating gender inclusive and affirming practices, and learning more about trans and gender diverse nurses, students, and educators' experiences would be really helpful. So with every research, there are limitations and strengths. And so this study was part of the limitations. It was limited to the English language, which meant excluding, in our context, French-speaking participants, so some folks from Quebec and New Brunswick. And this included excluding the nuances and challenges of such a highly gendered language. It also somewhat eliminated the vast understanding of gender diversity outside of English and French. The sample size, well, maybe not quite a limitation. There are some places that still see sample size in qualitative work as a limitation, and it does limit transferability. However, we did have representation, as I said, from across provincial contexts. And
those
sampling
people are
by
wrong.
I
If I
agree.
may.
Yes, yes. And sampling bias was possible, meaning that students and educators with an interest in this topic were more likely to participate. And strengths. So one of the strengths that came up sort of unexpectedly was that having myself as a trans and gender diverse researcher allowed students, in particular trans and gender diverse students, to feel safe and more willing to participate. We were able to capture students' experiences, including trans and gender diverse students, which has not really been done in nursing yet. And we were able to outline some of the steps to resist cisnormativity and advance gender inclusive and affirming practices. So our key takeaways, just to wrap us up here. The objective of my study was to explore and revision gender inclusive and affirming practices in schools of nursing. What I found is that cisnormativity is rampant and poses problems for trans and gender diverse patient care and trans and gender diverse nursing students. However, we reimagined schools of nursing and offered multiple levels of intervention to advance gender inclusive and affirming practices. So here are my references, and this is a slide along the Red River, a photo that I took on a bike ride, not recently, of a bison made out of books. And having moved to Manitoba, being from Ontario, the bison is quite tokenized and romanticized here, and I didn't understand why, but I've been doing lots of research, and the First Nations folks and Métis folks that are the traditional caretakers of the land, and how important the bison was. The education and bison go hand in hand. So I thought this was an appropriate picture for finishing off. So now I just have time for questions.
I just have feedback I'd like to give.
Yes, sorry, I can't see who's speaking.
Harmony, go ahead.
I could put my camera on if that's easier.
Oh, no, I see your picture now, or your name.
Okay. I just want to say I really enjoyed like your presentation, and like it really opened up my eyes to like what the queer community deals with, because like it almost feels like listening to what you were saying and like what people have gone through, like it's like your own like minority group, like a lot of the same stuff is what we deal with. And like to me it's just crazy how like people go out of their way to make other people miserable, and I didn't realize like how badly that impacted like the community. So I just wanted to say like thank you for like just being vulnerable with us and whatnot. I really liked it.
Oh, thank you so much. And I really, really appreciate that feedback and your keen ear to listen. Thank you.
Yeah.
Hi, Jess. I'm Dave. I'm one of the instructors in the Medicine Hat campus. And not a question, but just wanted to thank you for your work. I think it's really important work. And it's also very timely when you think of the sort of hostile environment right now that we're dealing with in Alberta around gender affirming care. So a really good reminder as educators and as nurses, just how important this is. So thank you.
Yeah. And Dr. Jackson and I have spoken a bit about that, the context as well. So it's something that's on my mind when I'm going into a new space as a gender diverse person and not knowing what the context is for the group. So I really appreciate Dr. Jackson and your cohort here for making a space that is safe and accountable, and I appreciate that.
Well, and Jess, thank you so much for joining us and sharing these experiences. Along with Dr. Cousin, you've given me a lot to like reflect on and like, oh, I need to do better at this. So know that I'm gonna take that away and continue learning. I think I really appreciated the way you presented, because the formal curriculum, we are just absolutely rammed full of information. So it's we feel the obligation, but exactly as you say, there's challenges there. But I'm realizing I can do more, so I'm gonna take that away and reflect on it. I also just very quickly wanted to put a plug in. So one of the things that my colleagues and I were on the hiring committee a couple of years ago for the faculty, and we saw that we looked at everybody's CVs, and the CVs from, or like curriculum vitae, like essentially your resume when you're applying for an academic job. We saw that people who were outside of nursing, so psychology, biology, who were applying for roles, they had started publishing work in undergrad when they were like summer students and this kind of thing. So they had tons of publications. However, we saw that the nursing candidates had only started publishing at their like PhD level. So they had way less kind of track record built up. And it didn't mean that they weren't doing the work. It's just they maybe hadn't been getting credit for it all the way through. So anyway, this has made it very clear to me that if we are going to get more diverse people at the professoriate level, we need to be building that infrastructure all the way along so that people are competitive when they go into it. And so I know publishing isn't the be all and end all, and we can endlessly critique that system, and that's maybe another conversation, but just to say, if you ever can imagine yourself in the academy, or maybe you want to teach one day, reach out to your professors and ask if you can be involved in projects. I'm not sure that students always know that they can do that. And almost always you will get a yes. Like it's very exciting to have people who want to be involved. And part of that is we can set you up for success so that if you do want to pursue additional education. You have the credentials so that you'll get funding and all of these kinds of things. So, yeah, I guess don't ever be shy to reach out to people if you want those opportunities because yeah, we've done a really terrible job of building that highway to get you there, but hopefully things will be getting better. So anyway, just a plug, if you want to do some research, email somebody, they will love to have some extra help.
Sorry, my mouse is on its way out, so I can't use it. Um, I absolutely agree with that, and I've been thankful to um, publish, to continue publishing, to be involved in a number of projects. Not as much in my undergrad, but I've just been invited to a project with Dr. Roy Hajiri Vijay at York University because a couple of undergrad students reached out to her to see if there was any research work that they could be involved in. And now I've been brought on to help with a tiny little writing project, and hopefully they'll get a publication. And absolutely, it builds, for better or worse, the currency of academia is publishing. So yeah, it builds some. I don't know what the word is right now, but it'll help you move forward if that's something you're interested in doing. And it's a cool learning process too. Thank you again for having me.
Thank you so much, Jess. And if you wish, I see there's some comments in the chat. Maybe you want to share how students could follow up with you if they were interested, or because it looks like there's a lot of interest in your great work. So
Yeah, I just launched a soft website. And I
right.
did as part of I did participatory knowledge translation, which I didn't really talk about because there's so much to talk about. But essentially the students had an idea for how they wanted me to share some of this knowledge going forward. And they wanted a gender affirming care specific nursing created for nurses resource bank. And so on my website, there's a link to that, and it'll be living. So I'm constantly updating it and would be happy to connect with anybody. My email's on there. If anybody wants to chat about research, about being queer in the academy or in nursing, be very, very happy to chat. So
Thank you so much. I'm grateful for your time and all of your knowledge you've shared with us today. So yeah, again, amazing. And we have the pleasure of having one more person joining us, Cassie Dirks. I believe you are here. So Cassie is an RN who works at the Royal Alexandra in Edmonton. And Cassie, I don't know where you have landed within the Alberta Health Services reshuffle, but perhaps you can tell us a bit more and we can learn from your experiences as well.
Yeah, absolutely. Thanks so much, Jennifer. Can everyone hear me okay before I get started?
Yep, good for me.
Awesome, perfect. So as Jennifer mentioned, my name is Cassie Dirks. I'm a registered nurse. I always say by background because I work in an area right now that's not entirely clinically focused, but I think it's sort of a piece of who I am at my core. I started out as a new graduate nurse at the ICU at the Royal Alec back in 2009, and I worked there for a couple of years in the ICU, and then actually went travel nursing. So I worked in a few different places across the United States, clinically in positions just in different ICUs in Florida and Texas, and then landed in Colorado, where if anyone's been to Colorado, it's just a really stunning state. It's actually not unlike Alberta, but filled with really amazing things and really amazing people. So I ended up staying there for about 10 years. While there, I had the opportunity to do a few different things that were career related. So I worked clinically for a number of more years at the bedside in the intensive care unit, and then transitioned into a clinical educator role where I supported an intensive care unit, patient care unit, so similar to like a med surg unit, as well as a cardiac cath lab, which was far outside my scope prior to that. So I had that opportunity there. I then moved into leadership and was able to work with all those same departments, which was a pretty awesome experience. a couple of years ago, I moved back to Alberta, where I'm fortunate to live here in Edmonton, Treaty 6 territory, where I spend a lot of time with my family. So that was sort of the impetus for coming back this way. And my career here has continued to evolve. I was fortunate to go back to work at the Royal Alec, which holds a very big piece of my heart. So I'm still casual in the ICU there. And then was fortunate about 3 years ago to start working with what were then called the strategic clinical networks. So I'll talk a little bit about the evolution of the strategic clinical networks into what they're currently called now, which are the PINs, the Program Improvement and Integration Networks. And the emphasis within the PINs is really to sort of integrate research and best practice into clinical care at the bedside. So that is the sort of background of my sort of history within my own career. And I'll maybe just share my screen and talk a little bit about the PINs. I did a little tech check before logging in, but maybe I'll just double check that you guys are seeing the presentation screen and not the screen with the speaker's notes on it.
We're seeing the speaker note screen right now.
Okay. Thank you so much, Jennifer. I'll just switch that out. Is that better?
Yes, there you go.
Okay, perfect. Thanks so much. Awesome. So our overall objective today, or my overall objective, is to just share with you the RN's role in research, how to best integrate it into practice, and then defining sort of what the emergency and EMS PIN is, how we impact specifically emergency care within Alberta, and then also just to discuss the ways in which the PIN supports the integration of research into practice, as well as contributes to an ever-growing body of emergency medicine research. So the PIN is certainly not comprised of just me. We're a group of dedicated multidisciplinary healthcare professionals, ranging from advanced care paramedics, we have nurses, physicians, we have admin staff that support us in the work that we do. And then we're part of a greater team that consists of frontline healthcare professionals, operational and medical leaders. We work really closely with patient and family advisors. We work with researchers, Connect Care Alberta staff, policymakers, and a number of other partners from around the province. Our work is informed by and done in partnership with the entire Alberta emergency and urgent care community. So I'm going to share a video with you that just introduces the members of our team so you can kind of get an idea of all of the different people that we work with. Within the video, you'll also see a discussion of the 5 priorities of the PIN that we're currently working on as a team.
I'm Sean Dowling and the medical lead.
Hi, everyone. I'm Sherry Kashuba. I'm the senior program lead. The priorities for our PIN are improving ED flow and EMS offload and throughput, enhancing staff and physician safety and wellness, implementing provincial clinical governance documents, developing an ED discharge pathway, and advancing anti-Indigenous racism and equity-oriented care.
Now I'd like for you to all meet our team.
Hi, I'm Karen Foodie. I'm Senior Operating Officer for Red Deer Regional Hospital and for the Sylvan Lake Advanced Ambulatory Care. And I'm also the co-lead for the ED EMS PIN.
Anne?
Hi, my name is Anne McDonald. I'm the Executive Director of EMS Provincial Operations. I am the co-lead with Karen Foodie for the EMS ED PIN.
Hi,
Eddie?
I'm Eddie. I'm the former clinical department head in Calgary and outgoing scientific director for the PIN.
Popey?
Hi, everyone. I'm Popey Karavitas, and I am the assistant to the emergency and EMS PIN.
Sheila?
Hi, everyone. I'm Sheila Kelly, senior consultant with the PIN.
Andrew?
I'm Andrew Fisher. I'm also a senior consultant with the PIN.
Kayla?
Hello, Kayla Diness, senior consultant with the PIN.
Rossman?
Hi, everyone. I'm Rosman Esmail, senior scientist with the PIN.
Terry?
Hi, I'm Terry Smith, senior consultant with the emergency and EMS PIN.
Nil?
Hi, Nilüfer Tarizadeh. I'm also a senior consultant with the PIN.
Cassie?
Hey everyone, Cassie Dirk, Senior Consultant with the PIN. We are also happy to have on our team Marlene Wheaton-Chaston as the program lead, unable to join us this afternoon. Thanks so much.
Perfect. Thanks so much for the comment on the music choice. That was, that was something we added just for a little fun pop to our team introduction. So
Yeah, anybody who perhaps went clubbing in the a certain part of the 2000s knows that one. So well done.
Yes, absolutely. That's what it reminds me of too, Jennifer. Well, I'm just going to speak a little bit. You heard me mention that I was a former member of the Strategic Clinical Networks. The Strategic Clinical Networks within Alberta Health Services have been sunsetted as part of an evolution to really support the continued growth as part of a learning health system. So no need for you to sort of like embody this into anything that you know, but I'm sharing this slide more for awareness. So you'll see in kind of that center, there are 8 different pins that focus on different areas within the healthcare system. A goal of the pins is to continue to grow AHS as a learning health system. So learning health systems are, the intent of them is just to iteratively implement and evaluate health improvement projects, leading to higher quality, safer, and more efficient care for patients, as well as better professional satisfaction for healthcare providers. So some of the principles hopefully really resonate with you. I think it's part of the reason I really love this work is because of some of the principles of a learning health system, but they include integrating research and clinical practice, engaging with patients and families. What you didn't see in that video was we actually have 4 patient and family advisors as part of our emergency and EMS PIN that really work with us sort of day in, day out to help really inform the work that we're doing to ensure that everything we're doing is reflective of sort of that lens as well. And then the last piece I'll say is that a learning health system really strives to integrate health data and analytics as part of their day-to-day work. You'll also see that the PINs report up through operational leadership, and operational leadership is really frontline staff. So that's ensuring that we are working very closely with clinicians just to ensure that all of the work that we're doing is something that's going to be impactful, effective, and able to be integrated at the bedside. So what does the emergency EMS PIN do? The vision is really to build an inclusive network that supports the advancement of evidence-informed emergency care for all Albertans. So we seek to enhance the patient and family journey through emergency care from the time that patients first seek care, whether that's through calling EMS or if that's presenting to an emergency or urgent care, until the time that the patient is discharged or admitted. We continue to look for new ways to make the best use of our resources, improve health outcomes. We really want to look to improve access to emergency care to make sure that all Albertans receive high quality care, whether they're presenting to emergency or urgent care. We also really strive to improve the experience and satisfaction of patients and families, and also clinicians, just acknowledging that there's a lot of interplay between those groups. The work is driven by education, innovation, and then practice changing research. And sort of the epitome of it all is really collaboration. So you saw in that previous structure the importance of frontline clinicians as well as patient and family advisors and a number of other partners. So what does that look like within Alberta? So in Alberta, we see about 2 million emergency or urgent care visits per year. Just for sort of a frame of reference, there are about 4.7 million people in Alberta. So if you think about that, like half of the people, if it's one single person, are presenting to the emergency department each year, just shy of. So within Alberta, to serve all of those individuals, we have 109 different sites, including 6 urgent care centers. So now I have a question for you guys. So you can just go ahead and enter in the chat, or you're welcome to come off mute and toss an answer in as well. But I'm curious how long you think it takes to translate current research into bedside practice. I'll pop over to the chat and see what people are putting in. Yeah, nice. Awesome. Yeah, C or D. So very much an appreciation from your guys' team about how long it takes. And It is 17 years. So by the time the research is integrated, it's complete. They've published a paper on the outcomes of the research, and then that's taken and using implementation science or knowledge translation strategies embedded into practice. And then we start to see that culture change where it's just sort of an expectation of day-to-day practice. That entire process takes about 17 years. And I'll just call attention to the reference within here as well. This research is from 2011, if you look in the bottom right-hand corner. So if you're curious about doing some additional research as part of your path moving forward, this could be a good area to look into to see if any of the strategies that have been incorporated over the past number of years have made an impact in reducing this number. So what is the RN's role in research? The RN role in research, just at a really high level, is to ensure that research and evidence are effectively utilized to improve practices and policies. And this will all lead to positive organizational and societal impacts. Seems pretty straightforward when you just put it as a one-liner. So with the PINs in particular, I definitely just want to acknowledge that whichever space you hold in healthcare as a registered nurse, your role in research will look a little bit different. It could incorporate all of these elements. It could incorporate sort of one small piece of these elements. So I'm going to speak to this, the RN role in research, and just acknowledge that this is from the lens of the PIN, the sort of like the PIN structure. So our role is to work with leadership and multidisciplinary teams, including managers, educators. We work with respiratory therapists, doctors, pharmacists, allied health, kind of anyone and everyone. And we use a data-driven approach to support strategic co-decisions with partners, which ultimately supports health system transformation, specifically within emergency care. We look to implement best practices that prevent the progression of illness and improve patient outcomes. So I'll just kind of highlight a couple of the key messages with these responsibilities. So synthesizing research facilitates the creation of guidelines or pathways that can be used at the bedside. So as an example, rather than having, a recently released paper being sort of distributed amongst the unit for everyone to read and integrate that into their own practice personally, as a department, we'll take that and we'll create sort of a guideline or pathway that creates sort of an easier integration strategy for clinicians at the bedside. Another responsibility is communicating effectively. Means we share meaningful messaging in common language that's really understood by all. And that's where our patient and family advisors are really important. They'll often sort of put their hand at mid-meeting and ask for clarification or highlight that we've used an abbreviation that doesn't necessarily resonate with them. So communication is really important. We engage partners to ensure that everyone impacted by the work has a voice at the table. This is really imperative and supports the overall success of the project. So you can imagine if you're the clinician at the bedside and you have a voice in the protocol that's developed that you're going to eventually be practicing, that means that it's much easier for you to incorporate that into your day-to-day work because you have an idea of how that's going to work best for you. Knowledge exchange and capacity building are sort of the ultimate goal of knowledge translation. Some approaches or words that might be familiar to you in this space include implementation science, change management, quality improvement strategies. We'll talk about PDSA cycles, so plan, do, study, act cycles. So these are all different strategies that we use to help disseminate knowledge. Lastly, we'll look at evaluating the work. That includes a data-driven approach to understand why and how a project is successful. We want to support sites in identifying areas of improvement. So we'll share data in report cards or progress reports. And our philosophy is that if you don't measure it, it's not always clear where you need to improve or if your intervention has been successful. So really kind of emphasizing the importance of data in the work that we do. And then you heard me mention how that ties into being an overall learning health system. So I'm a little bit mindful of time, but Jennifer, if you feel like it's appropriate, I'm happy to just sort of have people come off mute or share in the comments how you will ensure in your own practice, in your own role, how you want to integrate evidence and research into your role. Pop open the chat here. So I can share an example from my clinical practice, maybe while everyone's kind of thinking about how they incorporate it. So you heard me say that I work predominantly with the PINs at this moment in time, which means that when I pick up a clinical shift in the ICU, I oftentimes haven't worked in the ICU for a few weeks. So that can create some space where maybe I'm not familiar with a new policy, or I haven't done a skill in, maybe it's a month or a month and a half. So I had an opportunity to draw blood cultures somewhat recently, and I sort of took a step back before I was going to draw blood cultures, and I'm like, when is the last time I looked at what our actual protocol is here within the ICU to ensure that I'm doing it in alignment with what current best practice is? So we have kind of like a policy database within the ICU. So I took some time to go over that and then just chatted it through with my coworker who I was working with in the ICU to ensure that I was approaching that in a way that was in alignment with the current expectations on the unit, which were in alignment with current best practices. So you can see how in different roles, I make sure that I'm sort of pulling that research in different ways. So if anyone has anything they want to share in the chat, happy to have that popped in there. If you want to come off mute, maybe I'll give it just a couple seconds and then we'll move on.
Yeah, I know one time I had a patient that had, given the conditions that they had refractory diarrhea basically, and we could not figure out how to get it under control and this sort of thing. So I just looked up like research, incontinence, and like the person's diagnoses, and came up with something that said zinc had helped people in the community. So when we did rounds where everybody was there, I said, I found a study that said zinc helped people in the community with this. I know we're not in the community, so maybe we don't want to do that, but have we thought about this option at all? And the doctor said, I've never heard of that, but you know what? Zinc is a very low risk thing here. If this doesn't go well, there's not going to be any harm to the person. So let's try it. And so I didn't provide care. That was like at the end of my run of shifts. So I don't quite know what happened with that after, but that was an example of, for my practice, trying to say like, okay, rather than just accept like incontinence as a major implications for this person after discharge, can we try and do something to get it more under control here? And so to like look up some research quickly, read a little bit of it, and then talk about it in rounds. So I didn't make the decision, but could kind of put it on the table.
I think you highlight two really important pieces of integrating research into practice, Jennifer. One of them is curiosity. So I think, whenever we're presented with a problem, it's so important to just be curious about, hey, am I doing the best thing possible for this patient that's in alignment with current research and current evidence? Is there something more that I could be doing that would pull in some more of those parameters? So I think the curiosity piece is really important. And then when I heard you say that you brought it to rounds, so the multidisciplinary team, that collaboration piece is so important too. It sort of facilitates conversations. And I think the more that we ask questions, it helps build and grow that curiosity, which is how we sort of better practice for our patients at the end of the day, because it contributes to sort of further research, further questions. So we'll move on here. So I'm going to shift gears just a little bit and talk about, you heard Sherry Kashuba in the video that I shared talk about the 5 priorities of the PIN. So I'm just going to take a few minutes to share with you, embedded within those priorities, some of the actual different work that's going on within the PIN that's driving sort of best practices. So a priority of the EMS PIN, the ED-EMS PIN, is to improve emergency department patient flow. And so we have a few key metrics that we're looking at, again, thinking about how we're integrating data into the learning health system. We want to improve ED wait times and patient flow. And some of the specific metrics that we're looking at is we want to decrease the time to physician initial assessment, so when the physician's initially seeing the patient. We want to meet a 45-minute EMS offload target. And then we also want to enhance communication with patients in an effort to improve outcomes and experience. So you can hear that there's a lot of opportunities to develop best practices within that space. I'm going to focus on one in particular. It's the patient journey map and NOD ED communication tool. So we started by identifying a practice gap. So the practice gap that was identified was that there weren't tools that currently existed to support healthcare providers in utilizing evidence-informed communication strategies, and patients didn't really have insight into what their ED or urgent care journey may entail. So they would present to the emergency department and not necessarily have an appreciation for what that would look like. They're going to get triaged, and then they're going to get registered, and then they'll get seen by the nurse, and then they'll get seen by the doctor. And for someone that isn't working in the emergency department space, that can all feel really scary and intimidating. So we wanted to create a space where there was just more communication around that experience. So the solution, current evidence was reviewed, partners were engaged, and a tool was developed that was disseminated broadly across the province to support patient and healthcare providers in discussing the patient journey in the ED urgent care. So it's pretty small on the screen, but actually if you go to, it's still called the Emergency Strategic Clinical Network website, you'll find information on the patient journey map there. But essentially, once this map was disseminated, this was posted in every emergency department and urgent care center across the province. So patients could look at it and say, this is going to be my first step, this is going to be my next step. So it just helped with sort of setting some expectations for them about what they could anticipate in their journey to sort of help ease some of the angst and anxiety that can occur when you're presenting to the emergency department. Once this was complete, it was still identified that there remained opportunity for additional communication around this. So the tool addresses the need identified, and it's been proven to demonstrate empathy, improve clinical outcomes, and reduce burnout caused by miscommunication. And the communication that I'm referring to is the NOD ED tool. So essentially what this looks like is whenever you present to a patient in the emergency department, you want to greet them by their name and then acknowledge any family or friends in the room, as well as introduce yourself by your name. The next piece is occupation, so explaining your role as a registered nurse or whatever capacity you happen to be there in. Your duty, so explain what you're there to do. And then E is explanation. So as you're sort of doing anything with the patient, so if I go back to my drawing blood cultures example, I would talk them through each step of that. So I'm going to set up my sterile field over here. I'm going to approach my patient and so you just sort of talk them through each step that you're going to do. And then lastly, duration. So duration in the emergency department and in any area, not just the emergency department, can sometimes be really difficult to assess. So I always just remind people, just speak to what you know for sure. So I'm here to draw blood cultures. This will take me anywhere from 5 to 15 minutes this afternoon. So you're just giving them some context and help, again, alleviate any unexpected things that may come up. So that was the solution that we integrated. The impact of the evidence-informed tools will be experienced by patients, families, and healthcare providers. So patients and families will be better informed about their ED and urgent care journey, which will then increase satisfaction and ultimately hopefully help with treatment tolerance. Healthcare providers are creating more authentic communication moments, and there's actually been research that shows having more authentic communication moments with patients reduces the experience of burnout. So the impact is really sort of twofold. It benefits patients and families, but also benefits healthcare providers. So next, we just chatted about sort of the ED EMS PIN priority and helping address ED patient flow. Now we want to talk about strategies to improve staff and physician well-being. I guess there's sort of like 3 buckets of work that roll up into this. So we want to develop strategies to improve staff and physician well-being, but we also want to identify any strategies that already exist out there within literature. We also want to inform operations and operations about staffing patterns and any sort of modifiable factors that could contribute to harassment and violence. So currently we're looking at things like how does overtime factor into the experience of harassment and violence and those sorts of things. So very early stages, but pretty interesting. What I'm going to share with you today from this kind of broader bucket of work is something called info debriefing. So info debriefing, info stands for immediate, not for personal assessment, fast facilitated feedback, and the opportunity for the team to ask questions and clarify events. So The practice gap that was identified is that debriefing cases really is important in improving patient care. It also really promotes growth and self-reflection for the professionals that are contributing to any clinical experience. Currently within Alberta, there's not a standardized approach to debriefing, and a lot of times it's not occurring in clinical settings. So the solution that was developed is info debriefing, and the emergency EMS PIN didn't develop this solution. This was actually developed by a team out of Calgary, so it's been integrated into a couple of emergency departments in the Calgary area. It's a voluntary debriefing process. And the work of the emergency and EMS PIN is to help support the integration of info debriefing into any interested EDs and urgent cares across the province. Our hope is that it'll enhance patient care through addressing opportunities addressed during debriefing events, as well as enhance multidisciplinary collaboration. So here we're in more of an advisory role with the info debriefing team to help them implement in a way that leverages some of the evidence-based strategies that are embedded within implementation science to ensure that this is a successful implementation across the province. I'll move on to a third priority of the emergency and EMS PIN, and that's to support the development of clinical governance docs. You may have heard these referred to as nurse-initiated protocols. So within the emergency environment, changes are continual, they occur really rapidly, and as a result, there's a constant demand to address the learning needs of healthcare providers, and it's critical to ensure that providers deliver current evidence-based care and can work to their full scope of practice. So I see a note from Jen here that we're running a bit at a time. So I'm just going to share this on screen, chat about this really quickly, and then I'm excited to share the next piece of work with you in particular. So here, these nurse-initiated protocols, they're available both internal to AHS, but they're also available external to AHS. So if you scan the QR code on the screen, you'll be able to look at those nurse-initiated protocols. They're intended to be leveraged in emergency departments, and I'll just let you kind of peruse through them. And so lastly, I'm going to chat with you about advancing anti-racism and equity-oriented care in emergency departments. Emergency care settings are locations where racism against First Nations members is commonly reported within the healthcare system. And maybe I'll just acknowledge really quickly that the research that was done was specifically with First Nations members. However, the Métis Nation of Alberta have also been knowledge users for a lot of this work. So while we're specifically speaking about First Nations members, this work can often be sort of like leveraged in different Indigenous populations as well. So First Nations members are often overrepresented in emergency care settings, making up 9.4% of all emergency care visits, while only comprising 4% of the provincial population. So in collaboration with First Nations partners, it was found that First Nations members' experience of stereotyping and discrimination impact their choices about when, where, and even whether or not to seek emergency care. In interviews with providers, racist stereotypes resulted in First Nations members receiving less or lesser quality emergency care, as well as leaving care early much more frequently. Researchers also identified that First Nations members across the province receive lower or less urgent triage scores compared to non-First Nations members. So this was all foundational research that was done, which helped inform and create an opportunity for the project that we're currently working on in collaboration with the University of Alberta, as well as the Alberta First Nations Information Governance Centre, and then local First Nations community partners. So the project will work with 8 different First Nations organizations and 3 different emergency departments across the province to combat racism against First Nations members, educate and support clinicians, and then address barriers to continuity of care and ultimately to improve care in emergency departments. The project itself will focus on 4 different interventions. One being to build and strengthen partnerships between First Nations organizations and emergency departments. There will also be an emphasis on training emergency department staff in anti-racism and equity-oriented care. There will also be a look at making structural changes to department policies and procedures. and then in collaboratively documenting and advocating around health system issues that impact First Nations members' emergency care, but could be outside of sort of the scope of the project. We expect, as a result of this work, improvements in quality of care, patient experience, and continuity in care. So an example of this could be patients attending appointments at with the next provider after the ED visit. Results of the project will also provide valuable lessons on how to implement anti-racist and equity-oriented care with First Nations partners and emergency departments. And in addition, the project will contribute to literature by offering the very first observational study of interactions between ED providers and Indigenous patients anywhere in the world. Finally, partnership will enhance the capacity of Western healthcare leaders and researchers to support Indigenous self-determination and sovereignty within healthcare. So in conclusion, our journey through the role of the RN and the emergency EMS PIN in healthcare research underscores the indispensable role that research plays in advancing our understanding and treatment of medical conditions, specifically within emergency care. The wealth of knowledge derived from rigorous research not only propels scientific progress, but also significantly enhances the quality of patient care, and I would also argue starts to transform our healthcare system. The registered nurse is really a key member of the healthcare team, translating research findings into tangible, compassionate care at the bedside. The integration of evidence-based practices into the nursing profession really empowers nurses to deliver the highest standard of care, fostering positive patient outcomes and optimizing, as I said earlier, the healthcare system. Nurses are really vital contributors to the ongoing evolution of healthcare through research. Nurses serve in a role that allows us to be catalysts for progress, compassion, and excellence in healthcare. I mentioned it earlier, but research is formalized curiosity, poking and prying with a purpose. And with any of our last couple of minutes, I'm certainly happy to take any questions. And you're also welcome to email me at the address listed on the screen.
Questions for Cassie? I think it's really great to see that while, you know, professors in the university can do research, you also, this is part of clinical work and really integrated with everything that's happening in hospitals and care settings as well. So thank you for showing us what it looks like in a different context.
Absolutely. I think that's a good point. There is so many different places that research is sort of formalized in academic settings, but I think the ability to take that formal research and translate that into meaningful practice at the bedside is really important as well. And that's kind of where the emergency and EMS PIN comes in. It's helping kind of bridge that gap.
Right. Thank you so much.
Awesome. Thanks so much, everyone.
Yeah, please join us in clicking our clapping emojis to thank Cassie for joining us today. And this brings us towards the end of 485. So we made it, folks. I hope that you have all taken away some appreciation of research from our work and know that all of us, Dave and Tracy and myself, I'm sure I can say that we all did the best that we could to support you, and hopefully you got something you needed here. If not, I hope that you find that in the next step. So I think Caitlin, I see you have a question about when comments are due. I don't remember offhand, but I think it's in the syllabus. Dave or Tracy, do you remember when comments are due?
Sorry, Jennifer, comments for what?
For the videos.
Oh, I didn't. Yeah, I did mine a bit differently in Medicine Hat. So.
Oh, okay. I would say have a look at the course outline and I can get back to you after. I don't have it right in front of me, but Yeah, so I will stay around after for, I see there's some questions from people in my class. I'll stick around after for that. But we've got a few people doing wrap up in different places, so you'll see those in the chat. Before we go, I invite if you would like to participate in our affirmations. Totally optional, and you can hang up the call if this isn't for you, but thought we would wrap with a few affirmations before we go. So I belong here and I deserve to be here. I belong here and I deserve to be here. I am going to pass term 5. I am going to pass term 5. I am going to nail my exams. I am going to nail my exams. I am only going to say kind and supportive things to myself. I am only going to say kind and supportive things to myself. Dave and Jennifer and Tracy all believe in me, so I am going to believe in myself. Dave and Jennifer and Tracy all believe in me, so I am going to believe in myself. My ancestors are proud of me every day. My ancestors are proud of me every day. And one more, I am going to pass term 5. I am going to pass term 5. Okay, thank you so much.